Hi folks, this is Hariom. This is the third and the last part of what is normal movement. In this part, we will try to define what is normal movement. In the first part, we saw what are the characters of the normal movement, and we saw that the characters of the normal movement are variability. They change according to the environment. They change according to the goal of the movement, and in the next part, we saw that there are mm, three or three major ways of defining normal: the Gaussian normal, or the percentile normal, uh, the cultural normal, and diagnostic normal. So we will try to use all these three, all the both these parts, and we will try to define what is abnormal movement. Remember, if you are trying to measure something, you need a variable. So what I mean by variable is whatever measurement you want to use, so that we can put that into normal and what is abnormal. And the variable should be an indicator of health or a problem, right? So for example, why do they pick blood pressure? Because it is believed that if you have a higher blood pressure, that means it is an indicator of your health or a problem. It should be able to differentiate between normal and abnormal people. As I said earlier, it differentiates, blood pressure measurement differentiates between people who have high blood pressure, so that they have a higher propensity for cardiovascular disease, and normal people also. And also remember, it should have value for your patient. The patient should think that, okay, this parameter seems to be important. It will be the this point and this point, that is the health indicator and the value of the patient, they should go hand in hand in enemy. And remember, any variable you choose, it is for a context or for a particular environment. In terms of movements, it is for a particular environment or context. As I said earlier, blood pressure, you want to define what age group, what uh, disease they I mean, sorry, when was it measured, during treadmill or at rest, that kind of thing. So we will use these ideas here and try to use it in for a normal movement. So the first definition we saw is the Gaussian normal. So if you are going to use Gaussian normal, the first thing you want to do is we want to pick a variable. What variable is telling us, okay, this is a good indicator for um, a goal-oriented movement. Remember, that is very important. For a goal-oriented movement, what is a good indicator? There are two variables I have picked for this presentation. One is trajectory, another one is increase in joint movements in some of the joints which are participating in the goal-directed movement. Then the next thing is you want to define what is abnormal and what is normal. Remember, beyond two standard deviation, they will consider it as abnormal in terms of Gaussian, but we can also push it somewhat, right? We can say it 80% or something like that. But if you are going to do Gaussian, it's going to be 90 to 95% should be normal. Beyond that, if you are moving beyond that particular limit, we will consider it as abnormal. In the abnormalities, we have two things which is usually used in terms of clinical representation. One is called as the compensation, other one is called as the substitution, right? These are all, if you have compensation or if you have substitution, they will consider that as abnormal. The third step is do the movement and then find out whether you have normality or abnormality. Not when you are just lying down or just doing nothing, right? Remember, normal movement by definition, movement is when you are doing a goal directed movement. A goal directed movement, remember, is multi jointed, it is in a particular environment and things like that. So here we have made our patient, or it's not a patient, he's my old student. So we have made him do movements in two different environments. Remember, this is a small stool and this is a higher stool, slightly higher than this. and uh, we have taken two parameters. One is the trajectory of the hip joint. Probably we thought that that will represent the center of gravity. Not necessarily, but in a clinical setting that we thought like that. So it's the trajectory of the hip joint and the trajectory of the shoulder joint, right? And remember, we have defined this as, we can define the height of this chair, so to define the environment, or the starting position of your hips and knees, either here or here, whatever you want to define. So as I told you, you want to tell me where you are starting, how you are starting. And we have painted the pathway of those things, of the movement of the hip and the shoulder. That's what they call it as the trajectory. And remember, we can do it in many ways. We have just done it in a very crude manner, and you can see this is how your we will they will form a trajectory for sit to stand. Remember, you can do a trajectory for different things, but because it's easier to do it in a clinical setting, I have used trajectory of sit to stand in here in this example. So this is a normative trajectory. Again, this is another one of my good students who are happy to be our model, right? So this is what you will get: a smooth upward looking curve which goes forward and then goes up. Now, these are the true trajectories for people who had stroke, right? One person, you can see that he is having very difficult time in accomplishing the goal itself. Remember, the goal of sit to stand is stand up without falling down, right? So you can see his trajectory is not going forward, it's just going upwards. There needs to be a lot of here problems of stabilization and things like that. Here, another patient who is actually able to achieve the goal, that is, he is able to stand, but it is the whole trajectory is very uncoordinated. It looks ugly in a way, right? So you can say that these two are abnormal because it is going beyond the 2 degrees of, I mean, two standard deviation, right? Why? What is the value of having this trajectory? Because it's a single point measure for a whole movement, right? For the whole of sit to stand, we can have only one trajectory or one point, and then say that okay, uh, this is normal. This seems to be abnormal, kind of thing. And as I told you, we can do it for different environments, different height of stool, different if it is upper limb, different pointing tasks, different objects can be lifted. That kind of thing can also be done. And one of the important use it is used for is to say that whether the patient is improving or not. This is what they did in this study, which was on CAMT. These are normal trajectories in normal people. Remember, whoever, whether it is normal, you will have varied, but it will be more accurate here. You can see that there is variability, but it is more accurate. It is within the uh, one standard deviation. If you go towards this and this, these are patients before treatment, where you can see that it is a variable, but it is also, there are lots of errors. The accuracy is going down and probably moving closer to beyond two standard deviation, right? So this is how they will tell you that this is normal using trajectory, using a Gaussian model. So what are the limitations, right? One of the common limitation I can think of in a Gaussian model is, if you ask this patient who was standing up not in a Gaussian um, trajectory, right? He is not coordinating in the manner which most of us are coordinating. And if you ask him, okay, you are doing an excessive trunk movement or this and that, and he will be like, I don't care, right? So there is a mismatch between what we think is normal and what our patients think is normal. It can also happen the other way. I may think that okay, you are standing up normally, and the patient may think no, I'm standing up abnormally. So there is a definite problem in that. Your Gaussian may say that you're normal or abnormal, but you and your patient may not agree on that. And the other thing you want to understand is okay, if this patient's trajectory is coming closer to this, right, it is coming closer to the normal, will he be able to be uh, do more activities, more goal-oriented activities? Will he be able to sit and stand from all sorts of chairs, right? That is what we mean by varied environment. These are the questions you want to ask yourself, whether these are true or false. The next is you can use the Gaussian for as a range of motion. In the range of motion, they already have two defined definitions. One is compensation, other one is called as substitution. What is compensation? Remember, whenever you're doing a movement, this kind of movement, there will be some amount of shoulder elevation, some amount of shoulder elevation. So if it is going beyond a particular range, right, that is going beyond 2 degrees of standard deviation, we will say that it is abnormal. So when he was doing here, right, when he was trying out in this height, it doesn't seem to be that big a deviation from the normal. But here now, when you are seeing now, you can see there is a increased shoulder elevation, right? This in gait level circumduction, right? Those are all considered as compensation. The other, in case of ROM, what is the parameter they will use is substitution. What do you mean by substitution is there is an increased usage of this leg, this limb, this is your abnormal limb, rather than there is increased usage of your normal limb rather than your abnormal limb, right? So you are substituting one part for another. That's called as a substitution. So these are the two ways an ROM is mostly used for uh, abnormality, right? They use it for this is not aligned to this alignment is not that, this alignment, that kind of things. So what's the value of this? As I told you, it's easy to use in a clinical environment, but like in case of the earlier example of using trajectory, here also it cannot differentiate between people who are abnormal and normal, in the sense that okay, beyond this we will consider it as abnormal, beyond this we will consider it as normal, right? That kind of indicator is difficult. I will come to that in more detail also. And also remember, in this picture, if you are just doing this height, right, and if you are measuring, you will probably say it is not that abnormal. But when you are doing for this height, right, you will see that this seems to be more abnormal, or this is where you will say that there is a compensation. So if you are doing that for n number of environmental variables, it's always very difficult to do it in a clinical setting. And also we don't know whether if I am reducing this elevation, right, this elevation, if I'm reducing that elevation when you're doing this, will he be able to do a lot of upper limb activities, right? For in different contexts, in different variations, will he be able to do that? Again, that's a question for you to answer by yourself. So, what are the bigger problems in Gaussian? I will just summarize what are the problems in the Gaussian normal. Now, the first thing you want to remember is any parameter should be able to discriminate between normal and abnormal, right? Here, if you're abnormal also, the next thing you want to know is, if it is abnormal, what does it lead to? If I have a lot of shoulder elevation, does it lead to me functioning very poorly in all my upper limb activities, or in that particular goal oriented movement? Is it stopping me doing all those things? That you want to understand. And mostly there is a poor relation between what reducing these compensation and substitution, or reducing the trajectories towards the center, uh, that never seem to be clearly stating that it makes your person do more activity, that is less disabled. And also Gaussian normal seems to be um, comparing normal people to neurotypicals, right? That is, you're comparing a, a person with a brain injury to a person who is doesn't have brain injury, which is not a good thing for me. Say, for example, if you are comparing a cerebral palsy child with grade level or 4 of GMFC classification to a normal child, neurotypical, it seems to be very unfair, very unfair, right? So I've just given two pictures. Here you can see I have increased shoulder elevation when I am cutting, which should not happen, but this is happening because my friend brought me a frozen cake and it was so difficult for me to cut it even with a proper kitchen knife. It was not a cake knife or something like that, it was a kitchen knife. So will you call this as abnormal? And here also, this is the first time a patient is made to sit on a ball. You can see there is so much of substitution or compensation here and things like that. And then you will be thinking, oh my God, the patient is abnormal. But probably not, because of two reasons. Why are you making a patient sit in the Swiss ball? The next question is, we already saw in the first part, if you are very skilled, this will not happen. If you have poor skills, this will happen. So he may be actually getting better and these movements will get reduced as he keeps on doing. So to say that as abnormal seems to be not a great idea. The the most important thing is also beyond which, when will your patient leads to, beyond which range your patient will be more disabled, right? We want that cut off. Say, for example, if you take asymmetry, beyond what asymmetry your patient will become more disabled in terms of sit to stand. That is, he will have difficulty getting out of and in into an auto or into a car, right? Whether that asymmetry and these things have a relation, we don't know any of those things. So these are the common problems in Gaussian. I don't want to get into what are the problems in cultural norm. We can see that in our daily society, we consider whoever walks slightly different as abnormal, and they are constantly discriminated. And this is one of the biggest problems I have seen also. In terms of making the child look normal and walk normal, we are missing out on a lot of other things. That is, we are missing out on making the patient achieve other goals like going to school, full-time education, full-time job, and things like that. The last is your diagnostic normal, and as I told you earlier, diagnostic normal is the most important thing. That is, it tells you beyond that particular range. If you have a diagnostic normal, you can clearly say that that will lead to bigger issues. Here, in case of movements, beyond that particular range, your activities will be more and more difficult to perform. Beyond that, your variability is very poor and your achieving goal is becoming more and more difficult. Do we have diagnostic normal in case of stroke or cerebral palsy or any neurological deficit? It doesn't seem to be, and this is the bigger problem we need to work on. So all these have problems. So what do I recommend in case of your clinical setting? Rather than looking into normal and abnormal in a simplistic, I prefer a slightly simplistic manner. That is, whether they are achieving a goal or not. Rather than looking for ROM as a parameter or trajectory or a parameter, we can have goal as a parameter. Whether you are achieving your goal, yes or no. That is, you can have it as a diagnostic, yes or no, or you can have it linear. That is, he is doing it with errors, or there are a lot of mistakes he is making achieving that goal, not in the movement but in achieving that goal, right? So whenever he is standing up, he is falling back, or he is unable to stand from a particular environment, that kind of things. And if you are going to say that this is compensation, this is substitution and things like that, uh, uh, talk with your patient and see whether you want to work on that, rather than you yourself telling that this is what you want to work on. That is what a lot of places I see, they are keeping on working on trunk alignment. I don't know what is the fetish with that. And they just don't care whether the patient really wants to work on that or not. So that is my recommendation. And also, if you are comparing for normality, compare with their peers. Say for example, if you have a patient with cerebral palsy um, who is GMFC 4 or 5, compare them with other children who have 4 or 5, not with normal children, or even with children who are 1 or 2. And that, I think, is a big no no. Also, if you are comparing, say for example, in stroke, comparing severely affected people with severely affected people will make more sense than comparing it with mildly affected people. That is not a good way to look into it. And the last thing I want to say is, remember, normal movement is not what we are all achieving. We are never trying to achieve anything normal. We are all trying to achieve a lot of things in life. One of the common things we have found out in our data, Prakash and I, we found out that whether you are severely affected, less affected, you have normal movement, you have variable movement, we have accurate movement, or less variable movement, less accurate movement, whatever happens in terms of gait, most of them don't have social participation. They don't walk outside, they don't go to the they don't go and participate, they don't go to the shops, they don't go to their bus stop, to the auto stand. No, none of them are doing it. We want to work on that rather than working on just the alignment and normalizing. So, what do you want to? What I think we need to study more and come up with more. We want to first find out whether substitution and compensation and other abnormalities, other errors, are leading to more disability. That's the first thing you want to understand. The next thing you want to understand, beyond which range there is, if you have compensation and substitution and errors, leads to more disability. That is, you want to find out diagnostic normality. And we should stop with this obsession with normality, especially people who are obsessed with alignment of trunk, alignment of pelvis, all sorts of nonsensical ideas. So I want to end our three parts of our mm, uh, presentation on normal movements from one of the greatest scientists in cerebral palsy, Mr. Robert, who said, "What do you mean by abnormal movement? The child is doing what he can. Why are you worried about that?" So I want to we want you to think about that statement and see whether you are able to change your mind regarding any of your ideas about normal and come up with newer ideas, right? uh, Thank you so much for listening to our videos. If you have any queries, please contact us from all the information I have given you. Thank you.